Thank you very much. Welcome you all to today's webinar. This is our sixth webinar from Bangladesh Association of Oral and Maxillofacial Surgeons. On behalf of Bangladesh Association of Oral and Maxillofacial Surgeons, I am Dr. Manjuri Mahmood, working as the IT Secretary of BAMOS. Welcome you all to this webinar session. In this webinar, it will
facial trauma arranged by BAMOS as a combined effort of Foreign Affairs and IT Committee of BAMOS. The topic is very relevant to our situation and country as we have a high incidence of road traffic accidents and facial traumas. I am host Dr. Sajid Hassan, Assistant Secretary of Foreign Affairs. We have a fantastic session lined up and we are waiting to dive in. We have two presenters from India. They are very eminent surgeons, Dr. Jagadish Chandra and Dr. Ajay P. Desai. Before going to start the session, I am asking our President BAMOS, Professor Dr. Ismatara Haider, Madam, to say something about today's program. Please, Madam.
Thank you, Dr. Sajid, and I welcome all of you in this sixth webinar organized by Bangladesh Association of Oral and Maxillofacial Surgeons. Today we have two speakers from India. One is Professor Dr. Jagadish Chandra and another is Colonel Ajay. Trauma, I think they will cover the mandible trauma as well as maxillary trauma, though it is very important, but time is not too much. So I think it is they will not discuss everything in this 1 hour or 1.5 hour time schedule. So I think they will they will understand, and our trainee and our doctor will be understand, and they can ask some question from them and share the knowledge both side from our side and from their side. So I think through their presentation we can learn new things, some new things, and what they will do, and from our Bangladesh what we want to do. And other important person, Dr. Jimson, is very close to us because when 16th ACOMS in Chennai, they help us very much. So I would like to thank Dr. Jimson again for their cooperation and good hospitality and successful program 16th ACOMS very nicely. So again, thanks him again. It is through this program, on behalf of Bangladesh population and on behalf of Bangladesh Oral and Maxillofacial Surgeons, I would like to thank him. Thank you, and I would like to start their speech as well. Thank you very much.
Thank you, Madam, for your speech. And at the stage, I am asking Dr. Anwar Sadat sir, GS of BAMOS, to say something to the audience.
Thank you, Dr. Sajid, moderator of today's webinar. First of all, I would like to thank Bangladesh Association of Oral and Maxillofacial Surgeons, BAMOS, to take the initiative for doing the webinar. Actually, BAMOS has been doing the webinar since last 16 months after taking the responsibility for 2023-25 sessions. And thanks IT department of BAMOS and the International Affairs for taking the responsibility to conduct this session today for, I think, 1.5 hours. When I think that the webinar can be done with the collaboration of India, especially I knocked Professor Samson Jimson, and the person you people know very much, especially in the last Asian Association conference. And when I asked him, please give me 2 speakers, and he instantly gave the speaker's name. And hopefully these 2 speakers will enrich our today's program. And I congratulate him. He's Samson Jameson, professor, and he is the Professor of Oral and Maxillofacial Surgery, Sri Balaji Dental College, India. And to our speakers already, we came to know from our online poster and as so many ways. and hopefully it will be a very good collaboration, and our presentation will give benefit to our trainees. And I can see so many Indians also join this program, and hopefully we'll continue this endeavor in future. Thank you so much.
Thank you, sir, for your valuable speech. We have with us Professor Dr. Jimson Sampson. I am asking sir to say some message, to deliver some message to all of BAMOS members. Sir, please.
Thank you. Thank you for inviting us and for this program. And good evening, everyone. It is with great pleasure and honor that we extend our warmest greetings from India to our colleagues in Bangladesh. And I would like to take this opportunity to thank every one of you for the great support that you provided us during the ACOMS. So it was well appreciated, and thank you so much yet again. And this collaboration, thank you so much for this opportunity to collaborate with your association. It is going to be an excellent platform for the sharing knowledge and to discuss the emerging trends. As you rightly mentioned, the way we can interact to know what we do from the other side of the border and what you do from your side, I think it will be a great learning opportunity to both of us. And also to explore various innovative approaches and shaping the future of our maxillofacial trauma care. So I think that is a very important point to note. And also my sincere appreciation to the Bangladesh Association for bringing us together. And you have two fantastic speakers, Professor Dr. Jagdish Chandra, who's heading a department in Karnataka, who's vastly experienced. And the next speaker, Dr. Ajay Desai, is a Lieutenant Colonel and he's a fantastic surgeon as well. Very good speaker. And I don't want to stand in the way of their talk by prolonging my speech. And I wish you all a very successful webinar and happy learning. Thank you so much for this opportunity.
Thank you, sir, for your speech. I am not making you waiting for the program. After each presentation, there will be a 10 minutes question answer session. And at first, I am asking Professor Dr. Jagdish Chandra to deliver your lecture, sir. Dr. Jagdish Chandra completed his BDS in 1995 and completed MDS in 2000. Now he is working as a professor and head of the Department of Oral and Maxillofacial Surgery in Inepoya Dental College. He has published more than 15 papers in various journals and also contributed in many textbooks. I'm asking Professor to deliver your presentation. Please, sir.
Can you see my presentation now?
Yes, sir.
Yes, sir. We can see.
Very good evening to one and all. At the outset, I thank the Bangladesh Association of Oral and Maxillofacial Surgeons for inviting me to and deliver this lecture on changing trends in treatment of mandibular fractures. And I also thank my good friend, Dr. Jimson, who suggested my name to you all to deliver this lecture. Thank you, Dr. Jimson. I carry warm greetings from Inepoya University, which is located in Mangalore, that is the Karnataka state of India. We all come across the mandibular fractures in our clinical practice, and it is important that we restore the anatomical form and function with the particular care to re-establish the occlusion in the management of these injuries. All of us know that incidence of these fractures vary from state to state, and the male and female ratio is around 3.7:1 in India, while I noticed that it is around 6.7:1 in Bangladesh. And also we are seeing a lot of these edentulous or elderly mandibles being traumatized because of some fall or some age-related injuries. That is basically because of the increased life expectancy. And managing these injuries in today's fast life with utmost care to the patient, with the most comfortable treatment for these patients, is possible because of the timely innovations that has taken place in the diagnosis and management of these injuries. So when we talk about clinical evaluations or presentations, there's not much of change that we have seen over a period of time. Whereas in case of radiographic evaluation, we have seen drastic improvement in the way we evaluate these patients radiologically. Earlier, 4 to 5 decades back, clinicians were relying on these conventional X-rays like lateral oblique or PA view of the mandible to evaluate these injuries. Later, the OPG came as a boon, and which used to tell us regarding the little more finer details of the mandible injuries. However, these carried the limitations that whether it is medially displaced, laterally displaced, we were not able to identify that. So then came the CT scans and the CBCT as a boon for us, and this problem has solved because of these imaging technologies, and today we are able to three-dimensionally achieve the images so that we can visualize the finer details with major or precision in diagnosis. So that is the change that we have seen over a period of time now. The management protocols remain the same, but because of better diagnosis and treatment options, these have reinforced in the clarity regarding the following of these protocols. Today, there is a lot of emphasis on preservation of blood supply to the soft tissues and the bone, and early and safe mobilization of the injured part is something which we are looking at. So that is what I said. Today, the patients are in fast life. They want to get back to the work early so that these treatments do not take much time in rehabilitating them. As far as early management of these injuries are concerned, there is not much of change. We still use the bridle wires or bandaging techniques for the temporary stabilization of these fractures in order to achieve stabilization and relieve the patients from pain and developing some kind of infection because of the mobility till the definitive care is initiated. So all of us are aware that reduction is of two types, that is close reduction and open reduction. And also we have indirect and direct skeletal fixations, both internal and external. So in age-old days, or when we were studying, all these were something which were looked upon and everybody wanted us to know these things. These, you can see that these were all so bulky and so cumbersome in managing these indirect fixation techniques. So we used to use all these wiring techniques in order to achieve intermaxillary fixations. However, these wiring techniques had the limitations or difficulties of inducing periodontal problems, or these could not be used in patients with periodontal problems, or we have seen the residents or doctors injuring themselves with the wire pricks and glove tearing. All these were a problem. And most importantly, these procedures used to take a lot of time in achieving these maxillomandibular fixations. So that led to the innovation that is called as intermaxillary fixation screws. So these screws overcome the problems of these wiring techniques. However, they had the disadvantage of becoming loose over a period of time. So if for some reason we have to put the patient on intermaxillary fixation, it became a little difficult. Then came our hybrid arch bars, and to the right, what we are seeing is a variable arch bar, which we have designed in our department. So these had both the advantage of using wires as well as screws for retaining these arch bars in place so as to achieve a desired maxillomandibular fixation for a desired period of time. So all of us, when we were trainees and junior doctors, we were doing this. Whenever a pediatric patient with mandibular fracture has come, we used to take the impression and make the cast, then break the cast, and then reorient it, and then prepare these cap splints. And today, with the in this digital era, all we need to do is to scan and then digitally manipulate the fracture segments and then print the splints. So when we talk about various surgical approaches to the mandible, all of us are learned the various intraoral and extraoral incisions for the approaches to the various aspects of the mandible. And today, because of the improved ornamentarium, most of the fractures we fix intraorally, and the condyles are being addressed vigorously today because of better ornamentarium or plating system that is available to us using retromandibular approach, either using a transparotid approach or retroparotid approach. So both these techniques have given a beautiful results today, and various centers are practicing this technique or open reduction and internal fixation for the condyles, and we see more and more condyles being fixed today with these approaches. There is also a modified tragus edge approach for these condylar fractures, which address the fractures involving the high condyle through the tragal edge, which provided a beautiful or good access to the site, as well as little or no injury or damage to the facial nerve. Then today we have minimally invasive surgical approaches, either intraorally or extraorally, and it is very pleasing to note that many youngsters are getting trained in this minimally invasive endoscopic surgeries, and it is the way it has to be taken, and I fully encourage these youngsters to develop surgical skills in achieving these endoscopic reductions. So that will take care of majority of the condyles with minimal invasive techniques. So when we talk about minimal invasive technique, this is another technique which many of the centers follow, that is the transbuccal approach, which will help us to use an intraoral approach to reduce and stabilize the fracture and fix them using a transbuccal approach so that the external scar is minimized and damage to the vital structure is reduced. So that is something which is commonly used in many centers. So when we talk about the changes in the internal fixation, there is a transitional change from both in the semi-rigid as well as rigid method of fixations. So we have witnessed a drastic changes in both these fixation methods. And earlier, in good old days, they were using transosseous wirings, and later came the stainless steel mini plates, which were used extensively. And today we have the luxury of various sizes and shapes of the titanium mini plates, which help us in treating these fractures. We have also witnessed the development of 3D plating osteosynthesis, which takes care of shearing, bending, and torsional forces. They also come in different types to take care of the vital structures in and around the fractures. So as I mentioned earlier, the various designs of condylar plates have increased the incidence of number of condyles undergoing open reduction and internal fixation. We earlier used to use 2 mini plates, then later it came the various designs such as delta plates, lambda plates, etc. came into the market, which helped us to reduce these fractures. And based on the type of injury or fracture, we can decide on the type of the plate which will take care of the healing. In pediatric patients, due to the possibility of growth restriction and the plate translocation, we have tried using bioresorbable plates, and to some extent they are very good in their use. However, some difficulties are there regarding the cost, regarding the strength, etc. But however, in future, it's going to be, with the inventions and innovations, I feel this will replace the conventional titanium plates in pediatric patients. We also have the pensile bone plate, which are used in the cases of atrophic mandibular fractures, which have the advantage of both the mini plates as well as compression plates, so that these edentulous mandibles can be handled in a better way. So when we think of rigid internal fixations, we think of these dynamic compression plates, lag screws, which are also technique sensitive, and it required some expertise in handling and placing and fixing these plates. So today we have the reconstruction plates, which does this rigid internal fixation job, and we also have these locking plates, which are also added as a boon in fixation techniques to prevent bone fragments moving, and so that better adaptability and stabilization is there for the fractures to heal. Even though the virtual surgical planning is extensively used in cases of orthognathic surgery or complex reconstructions, however, it is being used in complex mandibular fractures as well, so that we have a good pre-operative planning, a good surgical splint fabrication, and Also, we can anticipate the possible complications and take care of that, and overall improved accuracy and a better outcome of the result is achieved using this virtual surgical planning. And also that duration of the surgery also is reduced, and another added advantage is that the patient is explained in a better way. He is able to visualize what is going to happen and what is there. So another important change or innovation that is happening in fracture management is patient-specific implants, which again are designed to fit the patient's anatomy and also achieve optimal bone incorporation and stability so that the healing is better and the cosmetic and functional outcome of the treatment is overall better. Some centers also use intraoperative C-arms, which help the clinician to visualize the fracture reduction and also fixation, whether it is proper or not. When we talk about changes, how can we forget these sutures now, which come with antibacterial coatings, which help in better tissue healing, and also we have better pain management methods. We are using these tapentadol nasal spray in managing post-operative pain in our trauma patients, which is giving a promising result. We can also use therapeutic low-level lasers, which can be utilized in our trauma patients to manage the post-operative pain and also improved movements of the jaws following the intermaxillary fixations. Again, this is one more study which we have done in our center, that is calcitonin nasal spray, which helps in healing of the bone. So, so the advantage of these calcitonin nasal spray is it avoids the systemic complications which arise because of the oral or parenteral supplement that is being taken. And also photomodulation therapy, where we have we use infrared or near infrared rays to manage post-operative healing and also the bone repair. So these are the few things that innovations or changes that has taken place in the management of these mandibular fractures. So what is the way forward? So when I see, I feel the future of managing these facial fractures is robotics and navigation. So this is extensively used in other parts of the body, and soon we will see this being extensively used. Of course, it is tried in few centers, but I feel it will be in extensive use in the near future. And today we see maxillofacial surgeons carrying bones, plates, and screws to fix the fractures. And soon, with the promising early results, I feel the maxillofacial surgeons will be carrying the bone glue to fix these fractures. The few of the initial studies have shown promising results, and hopefully there will be a lot of research and innovations that is taking place in this area, which will be the future of fixing these fractures. So with these few points on changes in innovations and treatment modalities on the mandible fracture, I once again thank the organizing committee for providing me an opportunity to talk about this topic, and Thank you all for your attention.
Thank you, sir, for your very detailed and insight of this topic, and we have learned and seen many new things in this field. We have some questions already. One doctor asking about, can you speak more regarding the complications associated with each mesenteric, transparotid, anteroparotid, and retroparotid approach during condylar fracture management?
The main complication that every surgeon is worried about is the injury to the facial nerve. So it is important that we understand the anatomy of the facial nerve well and prevent injury to that. However, because of the retractions or iatrogenic cause, we can compress this nerve, can result in early or which will result in neuroplexia and temporary damage to or injury to the nerve, which will recover over a period of time. So the problem comes only if you have transected the nerve during the procedure, then it is something which we have to take care of, and maybe early repair we may have to think. So that is one complication which we have to think of. Another complication is xylocele or salivary fistula. So what we do is when we are dissecting, we dissect the different layers and then suture it at while placing incision itself, we will change the direction little bit so that when the suturing takes place in a different plane altogether, so that the salivary leak problem is taken care of. So these are the two common problems that we encounter in transparotid approaches.
Thank you, sir. Another question from Dr. Mohiul Alam Siddiqui. Is there any role of allo bone materials in the fracture lines in case of bone deficient conditions? If the fracture loses any bone fragments, can we use the allo bone graft materials? Sir.
That again depends on the site of injury or whether it is infected or not. So if there is an infection, then preferably you take care of the infection, allow the early healing to take place, and then do a secondary reconstruction at a later date. But if the infection site is clear, there are some studies which have used this allographic material in the bone, which has helped in bone regeneration. There are some studies where they have used these graft materials over the plates as well for a better healing. But if there is an infection, then better avoid it because you may be heading for a complication.
Thank you, sir. Thank you. Another question from Dr. Nazmul. He is asking about condylar fractures. His question is, in case of intracapsular condylar fracture, can we use only screw rather than plate due to lack of space and approach?
Yeah, intracapsular fracture is actually a very debatable area. So it depends on why we need to address the fracture. So in case if the occlusion is stable, if there is no problem for the patient, just because fracture is there, we need not go and fix it. However, if it has to be fixed, definitely screw can be thought of. We have used these screws in a few cases. And there are some centers which have used lag screws as well in these type of conditions. Yeah. Definitely screw is a better option in case of intracapsular fractures. Otherwise, plate fixation may be difficult because we may not have sufficient bone to fix the other end of the plate, or it will interfere with the joint movements.
Okay, sir. Thank you, sir. another interesting question about postoperative imaging for evaluation of trauma cases. It's the question from Dr. Sarwar Biplab. How we can image the patient postoperatively to evaluate the postoperative condition, sir?
Best way to evaluate is clinical evaluation. And if you feel there is some problem, then accordingly we have to decide. If everything is fine and you just want to confirm whether your plates are in place, then maybe an OPG is a good choice. Otherwise, if you feel there is some problem associated following the treatment, then CT scan may be a better option.
Okay, sir. Another question from Dr. Ariful Islam. How we will approach in case of medial and anteriorly displaced high condylar fracture, sir?
Medially displaced high condylar fracture.
Sir.
Yeah. So in our center, we have been using the trigger edge approach to achieve the reduction and fixation of these kind of fractures. Again, it is a technique sensitive. High condylar fractures require a lot of training and skill to manage those fractures. Otherwise, to locate the fracture fragments and reduce it becomes a problem. So it depends on what you are comfortable with, you can go ahead with that. But in our center, we have been using that trigger edge technique.
Okay, sir. So I have a question personally. Sometimes we can see the intraalveolar neurovascular structure is totally severed. Then we definitely expect long-term paresthesia. But what is your experience? If we can manage it end-to-end adaptation by managing the fracture fragments very well, what is your outcome experience, sir, in these cases?
Our experience, there was not much of a problem. They are, most of them have recovered. Only problem happens when the bone is severely destructed and interfering with your inferior dental canal. Then that is where the problems will arise. In such situations, we have to see to it that the neuromuscular bundle is, cleared off from all these bone fragments, and you fix them later.
So that the canal guide to the regenerative fibers to communicate to the other fragments, other side of the.
I'm sorry, I did not follow your questions.
That means if we reduce it well, the intraalveolar canal guide the regeneration of the fibers.
Regeneration. That is what we have seen with the sagittal split osteotomies as well. At times the neurovascular bundle gets severed or disturbed because of this, especially when we are doing a setback. So, but over a period of time, it heals.
Thank you, sir.
Sajid, there are some questions from India.
Okay, sir.
Like Vikram Singh.
Okay, sir.
Okay.
Okay, sir. Another question from
Winston and Binay Krishna Kolari.
Yes, sir.
Can you see?
Yes, sir. He is asking about 3D role of AI and 3D printing in the present era, sir, regarding mandibular fractures.
Yeah, the role of 3D is actually in an extensive fracture or comminuted fracture definitely has a role. We can get stereolithographic models and analyze and then plan the fixations. Or we can also make use of these 3D images and AI to go for a patient-specific implant, which will again help us in case if the bone graft is required. In these patient-specific implants itself, we can plan the bone graft as well. So that will definitely help us. Only thing is takes time. So it also there is some learning curve. Not all centers are able to manufacture and give. So all these difficulties are there. Maybe over a period of time, definitely it has got a role.
Thank you, sir. Another question is regarding the atrophic mandible. How we can ensure blood supply is maintained regarding its open reduction, sir?
So basically, we have to understand the blood supply of this mandible, about the periosteal and endosteal blood supply. Also, we need to understand the centripetal and the centrifugal type of blood supply as well. So we should use, depending on the age of the patient. If the patient is elderly, then we should preserve the periosteum as far as possible, because invariably in these aged patients, the endosteal blood supply would have compromised. So that is something which we have to keep in mind. But as I said earlier, today the AVO principle or AVO gives a lot of emphasis on preservation of the blood supply to the both soft tissue as well as the bone.
Thank you, sir. We can allow one more question, and we have a question from Mosum Iqbal. He is asking about regarding the coronoid fracture. Should we remove it or we fix it, sir?
So again, it depends on what is the clinical presentation. If it is interfering with the mandibular movements, if it is causing some kind of disturbance or interference with your zygomatic arch, in such situations we may have to remove that. Otherwise, you just leave it like that. It will. Or in some situations, we also do fix it. In case if it is easily accessible and can be reduced and plated.
Thank you, sir, for your very lively and enthusiastic participants. We are going to our second presenter now. Thank you again, sir, for your detailed insight.
Thank you for all this thing. It was very nice talking to you all, sir. And hope to see you all soon in one of the conferences.
Thank you, sir. Thank you. Now, the audience, I am inviting the second presenter of this session, Dr. Professor Colonel Ajoy P. Desai. He is from Armed Force Medical College, Pune, and he will be deliver his presentation on mid-facial fracture, an overview. So I am asking sir to deliver your presentation, sir.
Sir, you can see my screen, sir?
Yes, sir. Yes, we can see, sir.
I'll just wait.
We can see you, sir, but not your presentation screen.
Yeah, I'll just few minutes.
Sure, sir.
Yeah. Sir, can you, is it, wait, I'll just see. Is it visible, sir? Oh, shit.
We can see.
Share.
No, sir.
Can you see my screen, sir?
No. Just see you, not your presentation.
Okay. Something wrong with the rights. Just check.
সজীব মঞ্জুকে বলো যদি হেল্প করতে পারে।
Sir, already, madam.
Sir, please share your screen, sir.
Yeah, I'll do it. Yeah, now I think it will be visible.
Yes, sir. Now it is visible.
Sir, it's okay now, sir.
Yeah. Are you able to see this slide, first slide?
Yes, sir. Sir,
Yes,
we can
sir.
see.
Now it is visible, sir.
First of all, I really thank the Bangladesh Association of Maxillofacial Surgeons of India, of the Bangladesh Association, for inviting me for this topic, and Dr. Anwar, Dr. Sajid for the kind introduction, and definitely Dr. Jimson, who has actually suggested my name for the same. Now, after we have heard Dr. Jagdish, who has already spoken extensively about the advances of the technological advances in management of the fracture of mandible, I would stick to basically basics. I mean, it is more focused towards the postgraduate students, will be my presentation. So this is the place actually where I work. That is the Department of Dental Surgery and the Armed Forces Medical College, Pune. So my topic would be under the following heads: the introduction, a basic overview of what is actually a midfacial trauma. Then about the basic surgical anatomy of the midface, what facial buttresses are, the classifications, the mechanism of injury by which we actually observe this type of fractures. The clinical features is basically for the postgraduates who are actually listening to this talk, the diagnosis and the management. I hope I am audible, sir.
Yes, sir.
Yes,
Yes,
sir.
sir. You are audible.
Yes. So coming to the next slide. Now, the maxillary bone help in the three major cavities of the face. That is the upper part of the oral cavity, the nasal cavity, the orbital fossae, besides the maxillary sinus itself, and which is small at birth, but as it grows and then assumes a more inferior position in the maxilla. So that forms the basic bulk of the midface. So we have the upper third, the middle third, and the lower third. Now we will concentrate more on the middle third, as we know. So various bones, as we know, the maxillae, the palatine bones, zygomatic process, and so on. Now the maxillary bones help in the formation of the three major cavities, as I earlier said. So coming to the surgical anatomy, is basically there are a lot of attachment of the muscles, the extraocular muscles, the buccinator, the facial mimetic muscles. The role is not very significant, but substantial in the displacement of the fractured segments of the midface. Now, the main advantage as a surgeon, as I said, there are several air-filled spaces present in the midface and having lining on both the sides. So that is actually our savior. So often than not, the midface is able to survive the comminuted fractures because of this periosteum from the outside and the specialized epithelium from the inside. And definitely in the thicker areas, we have the cancellous marrow. So there is a large extensive blood supply, which helps. Again, the facial skeleton, as we know, it is very unique. It protects the brain and skull. It actually acts as a shock absorber, as we call it. The force is transmitted to the condensed bone, that is the buttresses. However, there are areas of weakness, that is developmental sutures or air-filled spaces, which makes the skeleton weak. However, thus it protects the brain. Now, there is areas of strength, as we shown by the study by Seacher and Tandler. It is analogous to our architectural concept of support. So there is a high ratio of cortical to cancellous bone in the thickened areas. So we have the buttresses. They are basically bony pillars where if you remove the thin bones, they are the ones actually which connects the cranium to the maxilla via the orbitozygomatic frame, and thus forming the buttresses, the horizontal buttresses, the vertical buttresses, and the sagittal buttresses, as we can see. Now again, there is a unique feature of the maxilla or the midface, as it's oriented at or almost at 45 degrees to the occlusal plane. So any traumatic blow, it does not directly transmit to the skull or to the brain, and by thus it prevents the direct injury to the brain more often than not. Now, when it comes to mid-phase fracture, already there is a plethora of classifications which are available. So this classification actually forms more of a guide, of a basis for planning your surgeries. They can be based on the central or the lateral midface and or the combination, or we call a panfacial fractures, as we all know. Now there can be an associated, the central, upper central midface, as we call it, the nasal, orbital, NOE complex fractures in isolation as well, where we can have a serious kind of communication with the skull base as well in the form of a CSF rhinorrhea, or there can be a visual, that is, since it's the most visual part, the deformity also is quite evident. And of course, there can be potential emphysema, which can be occurred due to the collection of air from the ethmoidal sinuses or frontal sinuses as well. Then there can be an isolated dental fractures, the alveolar fractures, the partial fractures of the maxillas, especially in children. Then we have different types of palatal fractures. Different classifications have been given: the anterior fractures, the posterolateral fractures, the sagittal fractures, the parasagittal fractures, the paraalveolar fractures, and of course the complex comminuted fractures. Now this can definitely does not occur in isolation. They are always associated with the mid-phase fractures as well. And there can be even a potential type 6 fracture, that is a transverse fracture as well. Now, if you go to the history, Alfonso Guerin and then subsequently René Lefort, they carried out experimental studies in cadaver, and they found there are unique lines, which is the Lefort 1, a transverse line, that is a lower level fracture, as we call Lefort 2, that is a pyramidal level fractures. Then there is a Lefort 3 fractures. However, there are a lot of merits and demerits of the classification. Now, merits are that is simplification of fractures. However, they are not so simple in the present scenario. It is much more complex. So it does not explain the associated fractures of the cranial base, the other midface configurations, and is really unable to accurately predict the reduction techniques. So then there came the Marciani's classification, which he extensively further studied the same. So Lefort 1 he modified into Lefort 3A, 3B, 2B, and so on. So like this, like Lefort 1, Lefort 1A is the comminuted fractures. Then Lefort 2, Lefort 2A, which involves the nasal bone, Lefort 2 involves the NOE, and so on. Lefort 3 as well. Then Lefort 4. Lefort 4 is any Lefort 2 or 3. You get a cranial base fracture, Lefort 4A, where you get supraorbital rim, Lefort 4B, where you get supraorbital rim plus anterior cranial fossa, and Lefort 4C actually, where anterior cranial plus the orbital wall as well. Now, these classifications are not to confuse the students, but however, it is more to communicate so that when we address or when we document such cases, it's more for a documentation purpose as well. Now, Rowe and Williams gave a very basic classification which involves the occlusion or not involving the occlusion. That again, involving the occlusion, we have the central region where we have the fractures of the nasal bone, the NOE fractures, or we have the lateral region where we have the zygomatic complex fractures. And the important one, which actually will result in, because ultimate aim or goal of our surgeries is to maintain the function from an aesthetics. So occlusion. Now, fractures involving occlusion, we have the dental fractures, the subzygomatic, which is the Lefort 1 and 2, as we know, and the suprazygomatic fracture or the craniofacial disjunction, as we call it. So these fractures may occur unilaterally or may be associated independently with the fracture of the zygomatic complex, thus can lead to a panfacial fractures. Now, important thing, what is the mechanism of fractures? What is the factors which influence the displacement? Maybe due to the degree of the force, the direction, the resistance offered by the facial bones, the point of application of the force, the cross-sectional area of the object, and attached muscles. So just further explaining the same thing, if you have a force which is applied in anterior-posterior direction, if an object is small, it can cause low-level impact, can cause fracture of the teeth, mid-level can cause fracture of the nasomaxillary complex, and high level can cause a fracture of the nasoethmoidal complex. So higher you go. And by an object, if it's a large cross-sectional area, if it's a lower level impact, you get a dental fracture, or a mid-level fracture, you get a LeFort 2 fracture. Similarly, if the direction is superiorly and the momentum is small, you can get only a depressed fracture of the nasal bone. But when it's large, you can get a craniofacial disjunction or a LeFort 3 level fracture. And if the same force applied in the interposture in the inferior direction, and if the mouth is open, you can get a LeFort 3 fractures as well. So then now as I said earlier, midfacial fracture or midface is it's non-resistant to lateral direction. So you can get any type of fractures, which may not be sacrosanct. Always you will get a typical linear lines of fractures. You will always have a complex type of fractures, especially in the present scenario. So how to diagnose any maxillofacial injury? Now, obviously, the ATLS protocol, as we say, once we have done all the primary surveys, we have ruled out everything, we have ruled the patient is hemodynamically stable, when it comes as a part of the secondary survey, where we do the inspection, palpation, and the diagnostic imaging as well. So the extraoral examination is very careful, because more often than not, clinical diagnosis, you are able to diagnose the fractures almost accurately. So you look for obvious lacerations over the forehead, edema, ecchymosis, bony deformities, any ocular involvement. Now, the extraoral examination always begins from the back of the neck, cranium, followed by the upper face. You look for the areas of tenderness. You check for the mobility of maxilla. The eyelid separated, you check for the vision, check for diplopia, gaze disturbances, light reflex, any paresthesia. So these are you must be remembering these figures in Rowan Williams and Peterson. You check for the bimanual palpation, proceed with the intraoral examination, checking for derangement of occlusion, the gagging of occlusion, any lacerations, and you check out for pharynx if any laceration or bleeding is also there. Clinical findings, these are the most common findings. There will be a facial swelling, malocclusion, maxillary mobility. There will be elongated face, paresthesia, nasal bleeding, and rhinorrhea. But if we go to the specific, like a LeFort 1, especially for the postgraduates who are actually listening to the seminar, more often than that, we always overemphasize whenever our students present a case, usually we check for all of this. Ecchymosis on the zygomatic arch region within the buccal circus, the patient keeping the mouth slightly open, occlusion is deranged. There may or may not be a midline split. There might be a subluxation of teeth. The impacted fracture, sometimes there's a telescoping, but if you apply a slight movement, definitely there can be a grit or felt when you are palpating. Then the percussion of teeth may specifically give you a crackpot sound, as mentioned in all our textbooks. Hemorrhage in the maxillary sinus can be there in the form of bleeding through the nose. Then coming to LeFort or 3-level fractures, you can have a swelling, gross edema, the moon's faces or elongated face appearance, as we call it, or panda faces. Chemosis may be there in the eyelids, the eye, the nasal deformity may or may not be evident, especially if associated with the nasal bone on NOE fracture. There will be a deranged occlusion. Mobility of the midface may be at the level of the FZs, the FN level, or the pyramidal type you get at the zygomatic buttress or the inferior orbital rim as well. There may or may not be loss of function in the form of diplopia or anosmia, epistaxis. There might be a CSF rhinorrhea if there is a breach in the cribriform plate, or the associated frontal sinus fractures as well, especially the posterior table. In LeFort 2-level fractures, basically the movement being detected at the infraorbital margins and nasal bridge, as we have already spoken about it. LeFort 3, same again, as I told you, there's a dish face deformity, tenderness and separation over the bilateral FZs, maybe unilateral also. Gagging of the occlusion in the molar area. There can be a CSF leak, as I said already, due to disruption of the cribriform plate. So clinical features may or may not be evident, but definitely once we have assessed the patient clinically, we will be able to have a fairly or gross idea of what is going to be the next change of the next plan, that is the radiographic evaluation. Now, as Dr. Chandra already mentioned, like initially we had plain radiographs, the lateral skulls, but I would emphasize that students still should know how to read a good PNS view X-rays, to examine at a distance, check for any gross changes. You look for the hot sites or patterns. They may not be precise, but they are more likely zones, especially if you are in the peripheral center when you don't have an access to a computer tomographic scan. So we can have a systematic examination where in the books it's already given the Dolan's and Jacob's line for a Caldwell projection. And now this is a suggested algorithm, or we can have what kind of X-rays we can have for the various fractures. But with the advent of the CT, now our work has become much more easier. We have the axial, the sagittal and the coronal scans where we can do a 3D reformatting. We have a good view of the skull where we can know where exactly the fractures, we can localize them well, and definitely the planning. As we can see on these diagrams, we can have a great view of the fractures. We can see the depressed skull fractures, penetrating injuries of the skull, and definitely if any associated brain injuries are there, definitely we can help the neurosurgeon as well in determining the same, especially the skull-based fractures. Now 3D CT or the stereolithographies come in a big way, which already Dr. Chandra has mentioned. So we can have a great visualization of what, especially in the comminuted fractures, extensive fractures. We can use these models to actually pre-bend our plates and use them while doing the fixation as well. Now coming to the goals of management, our basic aim is to maintain or to establish the function, form, and aesthetics by establishing the width, height, and the projection. So we should aim at trying to aim the plating of all the anterior maxillary buttresses whenever they are involved, restore the vertical dimension, and thus the horizontal and the vertical and the projection of the face. And main aim is to re-establish the pre-traumatic occlusion. That should be our goal, because ultimately we have to give the patient a good function as well as the cosmetic restoration. And definitely, nonetheless, we have to provide a structural support to the soft tissues also by maintaining the contour and thus giving the good aesthetic appearance. Now, treatment cannot be generalized, it should be individualized. Basic principle is to construct from going from the fixed to the mobile, or you're coming from the fixed to the mobile, as I said, either from the cranium you press it downwards, or you develop from the dental occlusion and upwards. That is which when we talk about pan-facial fractures, I'll be explaining you that. Now, factors affecting the treatment strategies may be in the form of a multi-trauma. There are concomitant mandibular injuries, definitely play an important role in the management of this mid-face fractures. Now, principles of treatment. Now, initially, you can just allow by supervised spontaneous healing, like non-displaced fractures, or where there is minimal occlusal disturbances are there. You just put in a 2 weeks liquid diet, especially in children. Weekly follow-up after 6 weeks. Any complication, you do active therapy. There are instances where we used to do intermaxillary fixation by using the appliances and immobilization, which nowadays we do not prefer. External fixation, more of an historical value. External phase, now you can see they are very clumsy apparatus, martial appearance, as Sir has already told in the presentation. So at least, but we should know of, especially postgraduate, we should know how we have evolved over a very simple techniques now with the using of the mini plates. Then there was to be internal fixation. Now the main disadvantage of this used to be a shortening of the midface. We, as in myself, when I learned, definitely we were doing this. There are instances where we can use this wire suspension intermediately before fixation as well. And definitely now the era of the rigid fixation, that is open reduction and the internal fixation, which has come up. So that is by the mini plates and the screws. That is the current ideal form of fixation as given by Rowan Williams. And we have got the non-resorbable as well as the absorbable, like in the form of a polygalactic or polyglycolic implants, especially used in children. So protocols of treatment as given by Roderick and Shomek 1992 is basically an early repair, exposing all the fracture sites, precise anatomic reduction and semi-rigid fixation, and immediate bone grafting if needed, and definitive soft tissue repair. Timing of the operative repair, usually the initial concept was 5th and 8th day, but nowadays it is more of going for an early repair. You should have airway in mind always. Now, the surgical approach can be in the form of an extensive approach, especially for LIFO2 or LIFO3 level. We can have a coronal approach. We can have different types of scattered incision in the form of periocular transconjunctival approach for addressing the infraorbital margins. We can have the intraoral vestibular approach or deglobing approach for the LIFO1 level fractures. As we have shown, that is a circumvestibular approach. It's a very good approach. You can approach almost up to the infraorbital rim as well. This is the facial deglobing approach, as we told. The lower eyelid or blepharoplasty approach, when we can address specifically the fractures of the orbital rim and whenever the floor is indicated for reduction or fixation. The coronal flap, as we know, we cannot overemphasize that, but definitely this provides an extensive exposure, especially to LIFO2, LIFO3 level fractures, where we can address the supraorbital rim as well as the medial and the lateral rims and the nanoe complex as well. Now, the most important part after the exposure is the reduction. That's universal rule of mechanics, that is the manual reduction, hand manipulation, especially in the fresh or non-impacted fractures, or some kind of a special instruments which we all are aware, but especially for the postgraduate, the Rose disimpaction forceps. Along with that, we can use the Hayton-Williams forceps as well, basically to cause the motion where we do the downward and the lateral movements, as we call it, or we cause it movement to disimpact the maxilla. And especially when there is a palatal fracture, we use the Hayton-Williams forceps along with the same. Now I'll just keep the slide. Basically, immobilization of the mid-face fractures, we have the mini plates. Trans-osseous wiring, we can use it as an intermediate fixation, but definitely it is out of use now. There are various configurations of the mini plates which are available. Various materials were available, but nowadays we prefer definitely the titanium or the resorbable bone plates, especially in children. Now coming to specifically LIFO1 fractures, the maxillary buttresses can be exposed by the upper sulcus incision. Basically, fractured buttresses may be plated. At least 2 screws on either side of the fracture, like in this case. The LIFO2 or 3 may require an extensive approach, as I said earlier, and exposing the buttresses by the normal circumvestibular approach can be done. Now, irrespective of whether you are doing the reduction and fixation of the mid-face fractures, you have to concentrate that you simplify the fracture and bring it to a LIFO1 level, and then you plate the final, that is the buttress, where we support because what happens is actually the occlusion we can play around later, but if you have fixed the stable points, it becomes more easier to fix the maxillary portion, that is the taking care of the occlusion. And a LIFO3 fracture, as I said, especially you can, if sometimes, if any bone grafting is required, you have to take care by placing the bone grafts at a later stage in the sequence of fixation. Now, it's very important that whenever you are putting the MMF, you have to ensure that condyles are seated in position, especially when you are fixing the fractures at the LIFO1 level at the last. And once after internal fixation, if you see MMF is released, occlusion is checked. If there is a reproducible occlusion at the passive stage, you continue. Otherwise, if there is any discrepancy, you can always reassess your fixation. So the basic principles, if you remember this diagram, It is basically going from stable to unstable and simplifying the fractures, and basically you finish at the Lefort 1 level. So in this case, what we had done, this is a case where we had a right zygomatic complex fracture and along with the Lefort 1 level and Lefort 2 level on the other side. So you do not have always a common patterns. You can always have a varied pattern as shown by this case. So now complications of any surgery, of any surgery has always part and parcels of our surgery is complications. So usually leads because of the inadequate surgical planning. It can lead to deranged occlusion, poor reduction, especially in the Lefort level fractures. It often leads to increased facial weight and lack of facial projection. And so you have to have a good surgical plan in your mind before actually addressing the mid-face fractures. So to conclude, the goal is functional and cosmetic rehabilitation. However, the main aim, you remember, you have to establish the form, function, and aesthetics by maintaining the width, height, and the projection. And treatment should be tailored to each individual, and a sound knowledge of anatomy and good aptitude for mechanics and proper application of techniques will lead to superior results. So the take-home message that Lefort fractures can be addressed at all three levels. Adequate exposure has to be there if you want to address all three levels. And the management goal should be to restore the vertical and the horizontal projection of the face and restore the pre-traumatic occlusion. So these are my references. And thank you for the patient hearing. Thank you so much.
Thank you, sir, for your very detailed and informative presentation.
I am very apologetic. It was a little long. I thought I was addressing more of the postgraduates. I tried to cover a lot of information in a short time. Very sorry for the delay.
No, sir, it was very, it was recapitulating for all of us and very informative and helpful for all of us and also the junior doctors. So we have some questions already. One question from Shaju Ahmed, Dr. Shaju Ahmed. What are the management approaches for complex comminuted fractures of palate, sir?
Okay, now actually I forgot to tell one thing. Like as a student, we should always, whenever a patient is come to you, you should examine him well. There is always a role of the impressions, or I just forgot to overemphasize that you take impressions of the patients. You see, you make good. Basically, you if the mandible is intact, obviously, you make the arch form, establish the occlusion, make a good palatal splint, and then use this splint for your maintaining the width of the palate and then going for the buttresses. Because palatal and obviously there is always sometimes like more often than not there can be a split in the palate where we can use the pyriform rim as well also to additionally stabilize the same. But we should not go to fix all these palatal fractures. It is better to have a good impression and form a good palatal splint or normal acrylic splint. It can form wonders actually, because more often than that the palatal blood supply usually it is not altered unless and until there is an extensive laceration of the palate, which also will be taken care of when you establish the width of the palate by taking the or making the splint.
Thank you, sir. Another question from Mohsin Munir Khan. What you prefer treatment approach in case of unilateral mid-face fracture? Do you prefer closed reduction or open reduction?
Yeah, as I already said, the treatment strategies or options which are available with us, if there is a minimal disturb or there is no disturbance in the occlusion and there is no mobility as well, you can always keep the patient under observation. However, now with the advent of the rigid fixation, especially in our scenario where I'm dealing with serving soldiers who are fighting the war, so I want them to be biting fit, or I want them to function early. So definitely I would prefer a rigid fixation, or you can say an open reduction internal fixation. But whenever a patient, is come to you, a young patient, where he's not, employed in some extensive physical activity, or where there is no disturbance in the occlusion, I mean, you should not subject the patient to surgery unless and until there is a, deranged occlusion and compromising in function.
Sir, another question from Dr. Sarwar Biplab. He is asking about post-operative malunion or non-union cases where imaging is not very informative due to metallic artifacts. So how we can differentiate it from early osteomyelitis?
Oh, yes, this question actually was asked early also. I think we missed it out. Actually, the thing is, especially with the advent of the CT scanning, as you said, but there is a lot of artifacts, as you said. But now, first of all, you are, when examining a patient, you are not examining the X-rays. You are examining the patient clinically. First, you have to see whether the occlusion is disturbed or not. You see the function of the patient, whether it's compromised or not. And then, now coming to the next part, that is the seeing whether, there is a chance of an pressure osteolysis, or you call it early osteomyelitis, as you said. The patient will definitely have some symptoms. There will be a signs, maybe in the form of draining sinus or not, and then you go for a radiographic examination. So your clinical examination always will guide you to identify, and then identify this early myelitis. Now coming on to the question of the malunion or non-union. Now non-union, obviously after fixation, if the fracture does not heal beyond 3 months, you call it a non-union. Now malunion obviously will present with your, if does not involve the occlusion, obviously there will be a facial deformity, but if there is involves occlusion, there will be a deranged occlusion. So in such cases, if I go further, we would plan these cases to manage after once all the fractures have healed, maybe 6 months time, all the fractures to be healed. And then if you want to address, we can address it as a fresh case, like doing a leaf-4 osteotomy or anything like by planning through a virtual surgical planning and so on, or plan a orthognathic procedure for the same to correct the occlusion. So our aim is basically to take care of the function.
Yes, sir. Thank you, sir. Another question from Dr. Mohiul. He is asking about the CSF leakage management algorithm. So what is the approach we should take early, measures take early, and then go in complex manners? What is the treatment management algorithm, sir?
Actually, the CSF leak management protocol is already, it's a very established thing. Now it depends upon what level the fracture has occurred. Now the thing is, the CSF leakage as such, we will ourselves definitely will not manage ourselves, but definitely taking into, we always should take the help of the neurosurgeon as well. However, more or less, or even we have come across, like we have done a good reduction, fixation of a leaf-4 level fracture, and the patient is now developed a CSF leak. Sometimes it resolves spontaneously, but however, again, as I said, the clinical findings, if the patient is going into the symptoms of retrograde meningitis, or which is at a later stage. However, now as such, I have a very limited exposure in the endoscopic approach to this management. We always take the help of the otolaryngologist or the neurosurgeons for the same. If it is a leakage which is very minimal, or we are not able to identify. But obvious fractures like frontal fractures, where you have anterior table fractures are there. The posterior table fractures are there. You have the cribriform plate of ethmoid which is fractured. So usually all this CSF leakage, there is actually this is a topic in itself. Will take a lot of time to discuss it. But in overall, if there is a CSF leakage, as we know, we should wait and watch first, and then usually it resolves spontaneously. But definitely, if it's a long term, and sometimes there is an advanced neurosurgical or otorhabdial procedure is required for the same.
Okay, thank you, sir. Another question from Dr. Helaluzzaman. He is asking about the management protocol of plastic mid-face injury, sir, where there is complex injuries of soft tissue and both hard tissue, sir. If you
Yeah,
can.
definitely. Now, this is actually our, especially being in the army, we see a lot of these cases, especially the ballistic injuries, where we should know thorough knowledge about the ballistics, the type of missiles actually to know or to treat this injuries extensively. Now, there can be different types of ballistic injuries. Maybe it involves only the soft tissue and hard tissue, and so on, where there is a loss of the or evulsive kind of injuries as well. Now, whenever we approach this wound, obviously the ATLS protocol has been taken care of, the airway has been taken care of, and then our work comes into picture, where we actually we try to debride the wound. In the first instance, if there is an extensive injury, open injuries are there, we debride the wound. There are small bony fragments which are there, which can be a potential source of infection. We remove them, and we try to achieve a good soft tissue closure as possible in case of large injuries. Whereas in the case of only like if by doing an imaging, you already aware like the bullet has penetrated and it has caused only a linear fracture or so we can manage it. By the conventional approaches. But however, the soft tissue plays a very important role. So we should not be too heroic when managing or fixing all the fractures in the first go itself. We should manage the soft tissue cover so that extensively we are able to give a good. We do not compromise on the blood supply of the maxilla or the midface, and then we can always treat it as a secondary deformity. But nevertheless, in a tertiary care center, whenever all the facilities are available, we have our good team in hand, we can always do an extensive approach to the fractures as well.
Thank you, sir. Another question from Dr. Saju Ahmed is regarding the zygomatic complex fracture. In case of open reduction and plating is not possible due to extensive comminution or extensive comminuted fractures. What we can do for aesthetic and occlusal correction? Aesthetic correction mainly, sir. Occlusal correction.
Yeah, okay. Because occlusal does not come in
aesthetic correction, sir.
Yeah, basically, now if you have an extensive zygomatic comminuted fractures, now we should always, in the first instance, if there is a compromised, soft tissue cover there, we should wait and watch, or basically you take care of the soft tissue, as I said. But now, whenever there is an extensive comminuted fracture where we are not able to, fix or do a plating, we should at least try to get at least the stable points of fixation. That is at least at the level of maybe an FZ or a buttress fracture, if at the level of the buttress, so that we can have a kind of a just orientation of the maxilla, of the zygoma as such, or we wait and watch and see if the residual deformity, how it's evident at a later stage. And there are a lot of now the PSIs are coming up for that, where we can do the surgeries for the same.
Sir, I have a question regarding the Lefort fractures. How can we check the patency of frontonasal duct paraoperatively? And how can we manage it if later develops frontal sinusitis or mucocele or infection like that, sir?
Now, whenever we do actually, if on the clinical examination, so definitely yes, we have already diagnosed it as a case of a Lefort 2 level or whatever Lefort 3 level fracture along with the frontal sinus fractures. Now, basically what we do here in our center is like we do all the sections of the coronal scans, or we CT scan. We advise is around 0.6 mm sections, so we can always visualize first of all the structure of the frontal nasal duct. In advanced cases where we are, cases where we can do a cysternography later on, MRI cysternography is advised. And definitely there are other methods as well, especially when we are treating with, especially when we are addressing the posterior table is intact, but anterior table is not, it's fractured, and we can see an obvious blockade along the CT, we can address that. But however, as you said, in the post-op, sometimes, patient as a long-term, even patients have developed cyanosil or the mucosal, sorry, after around more than 1 year, 3 years, 5 years also. So in those cases, then you have to go for an open approach where we have to drain the sinus. Either you carry out a obliteration of the frontal sinus obliteration. If the posterior table is intact, we can do that.
Sir, another question regarding choice of material in case of isolated blowout fracture. Which material is preferable to you, and the availability of this material in your country, and what is the difference of outcome of this material, sir?
Okay, are we talking about, sir, impure blowout or blowout? I mean, orbital blowout fractures you mentioned.
Yes, sir, orbital blowout fracture, sir.
Okay. So now, we are using, there are dynamic meshes which are available, titanium meshes, which we are extensively using. But we have an experience like in, suppose these are talking about the immediate, when you are treating or you are addressing the immediate blowout fractures. But there are some instances where patient come to you at a later stage with, inophthalmos, diplopia, the restriction of the ocular movements and all, where there is an extensive floor fractures and all. We are also experienced or we are using the 3D planning to build the orbital PSIs as well, so that the globe is supported well. Because the titanium mesh does not support, especially in the late or delayed fractures or orbital blowout fractures, it does not give that much of support where we can correct the inophthalmos and the diplopia. I am talking about the late stages. But the early orbital blowout fractures, we extensively use the dynamic meshes which are available. Other materials like we have not much experience on that, because there are plastic surgeons which they use this polyethylene materials and all. But I don't have personally any experience on that. But we use the mesh, which is dynamic mesh, extensively.
Okay, sir. Thank you, sir. Another question regarding the frontonasal duct patency. What material you use in your center for assessing the patency of frontonasal duct in case of frontal bone fracture?
Yeah, sir. I already told regarding basically you have a good CT scan, that is the 0.6 mm CT scans where we see in the coronal sections. We have also done in patients the cysternography as well to check, but that is only when advanced cases. Otherwise, clinical examination and the basic CT or coronal examination will give you a fair idea of the patency of the duct.
Sir.
We may use dyes and all, but nowadays we do not use that much. The MRI cysternography probably is the gold standard nowadays.
Thank you, sir. Another question from Dr. Mausumi Iqbal. He is asking about the management of nasal septum and nasal bone fracture management, sir.
Yeah, now regarding the nasal septum fractures, now we should be more concerned about the hematoma there. Septal hematoma is there. That we should be able to early identify. Otherwise, the nasal bone fracture, even minor displacement can be managed easily with the close reduction. However, when we are dealing with, once you have finished your Lefort 2 or Lefort 3 level, when associated, as we talked about the Marcioni classification, where we have nasal bone fractures, once you have done the base foundation, that is Lefort 2 or Lefort 3 level, you are addressed, we can use your Walsham forceps and the Ash nasal septum forceps to reduce it. I mean, first of all, refracture is reduce it. And what we use is, we use that ready-made splint which the ENT people use for the external fixation, so that is indirect fixation, so that the soft tissue over the nasal projection also is well adapted, and the septum and the nasal bone is taken care of. But when there is an extensive septal fracture, obviously we would need a maybe in the form of an open rhinoplasty or the cantilever rhinoplasty, we'll have to use if there is an extensive loss of the septum where there is a complete loss of the dorsal support of the nose or the projection is lost.
Thank you, sir. Thank you, sir. I think we have covered all the available questions, and it was a very informative session, sir. And we are glad to have your valuable presentation. Thank you, sir. And this is all from today's session. And it's a huge thank for the both presenters from India. And at this stage, I am asking Dr. Desai sir to conclude your presentation, sir. Sir, you have anything to say, sir, to the audience, sir? Desai sir.
Oh, sure. Thank you so much, Dr. Sajid and Dr. Anwar and ma'am, for having me on this platform. I'm really great. At least I've spoken to my Bangladesh counterparts. I'm lucky to be interacting with you all. And thank you for the patient hearing. I'm really sorry for exceeding the time. My apologies.
No, sir, it's all right, sir, but we are enjoyed your session very much, sir. And at this stage, we are looking forward to hear from Professor Dr. Mohiuddin, sir, President-elect BAMOS, regarding the program and for thanking our guests. Is sir available here? Everyone can...
Dr. Sajid,
Sir.
with your permission.
Sir, please, sir.
That is a very, very engaging session. I was a part of answering all the questions. It was really amazing. Thank you so much on my behalf and on behalf of colleagues.
Okay, Dr. Sajid, I think our President-elect Professor Dr. Mohiuddin sir is in the car, so he will not connect. So I would like to thank the two presenters, Dr. Jagadish and Dr. Ajay, for the excellent presentation and the interaction. I think this the portion of interaction was very good, and our doctors and trainee asked many questions, and all the presenters answer very nicely. So I think this interaction was very nice. So I'd like to thanks again both the presenter and for their good presentation in our webinar. So on behalf of our Maxillofacial Surgery Association, I would like to thanks again both the speaker as well as Dr. Jimson. Thank you very much.
Thank you, ma'am. Thank you so much.
So that's for today, and we are looking forward for our next webinar event. Until then, goodbye, everyone. Hope best for the future for everyone. Thank you very much.
And
Thank you.
one important thing, the student participant was more, I think, 77 participants. So I'd like to thank our participants, those that are attending in this webinar. If the participant is like this, so we can continue the program in every month or twice in a month. So I think this type of topics or another topics can be continued in our webinar in the maxillofacial surgery. So I think, Dr. Anwar, if you want to say anything, and then we can conclude the session.
It's okay. Actually, we passed 1.5 hours already. Thank you, Dr. Ajay and other speaker for your wonderful presentation. The special thing that I enjoyed that participants are from both
Thank you.
Bangladesh and India.
Thank you so much.
Thank you one and all.
I'm honored to be a part of the Bangladesh Association.
I think all the credit, maximum credit goes to some who helped me a lot to identify two very, very good presenters. And my thanks to all the participants. Actually, without participation, no session can be reached. So, gratitude to all, and thank you and good night.
Thank you, sir.
Thank you.
everyone.
Thank you. Good night.
Thank you all.
Dr. Sajid,
Sir.
hey,